Welcome to Module 12 of Nursing 542. This week's module addresses the diagnosis and assessment of musculoskeletal conditions in the primary care setting. Cauda equina syndrome is a surgical emergency. Symptoms include acute onset of urinary incontinence or retention, fecal incontinence, and saddle anesthesia. Patients will also have low back pain and bilateral lower extremity weakness and numbness. This condition is caused by pressure on the sacral nerve root and ischemic nerves. All patients who you treat for low back pain should be educated about the possibility of developing Cauda equina syndrome and be instructed to proceed to the emergency department should it occur. Emergency spinal decompression is the treatment. Septic arthritis should be suspected when patient presents with single swollen painful joint with decreased motion. Most patients will present with fever, but older patients are less apt to be febrile. Open fractures need to be treated with typically with surgical irrigation and possible debridement within 4 to 6 hours of injury. Any fracture with an open wound in the vicinity should be presumed to be an open fracture, not just those with bony protrusions. Better to err on the side of caution and avoid osteomyelitis, which is always a risk with an open fracture. Always be sure to assess circulation and nerve function distal to a suspected fracture. In primary care, you will definitely see a lot of patients with musculoskeletal complaints. Most are self-limiting, but others can lead to further injury or illness if not properly diagnosed. It's a very common reason for office visits in primary care. It's the most common cause of lost workplace productivity in the United States, and over half of all older patients report some musculoskeletal difficulties. Musculoskeletal assessment. The history of present illness is particularly important with musculoskeletal complaints. Was onset rapid or gradual? Was there an injury? What was the mechanism of injury? Are the symptoms chronic or acute? They're considered chronic if the symptoms have persisted for greater than 6 weeks, acute if less than 6 weeks. I've posted a link to a site with musculoskeletal examination demonstrations under the required reading for this week. The demonstrations are much easier to grasp when you're able to view them versus my giving you a narrative description of those examinations. The Harrison's text has a great algorithm for approaching assessment of musculoskeletal complaints. I will provide assessment/examination tips as I go through each disorder, but that is a good resource for the general approach to musculoskeletal complaints. One general recommendation that I would add to the Harrison's approach is to always examine the joints above and below the joint of complaint. I cannot tell you how many patients I've seen with a shoulder injury that have presented with elbow pain, or patients with hip disorders complaining of knee pain. Also, whenever a patient complains of non-articular lower extremity discomfort, you should always assess for lower back disorder or radiculopathy. These are the common complaints that patients with musculoskeletal disorders will present with. The complaints may be acute onset related to a known injury, sudden onset with no known injury or incident, or gradual onset without degenerative changes. Common locations for sprains are ankles and wrists. Generally, a patient will be aware of injury turning their ankle or falling onto their wrist. The Ottawa rules are a tool helpful in determining whether or not an x-ray is warranted. I've included a website here with those rules for your review. If tenderness is generalized, swelling is moderate, and little or no ecchymosis is present, then you can typically forego an x-ray. If there's point tenderness, range of motion is clearly decreased, there's significant swelling and ecchymosis, and or the patient is unable to bear weight, then you'll want an x-ray to rule out fracture. Stability of a joint is difficult to assess in the acute phase of injury. More accurate assessment of stability can be done after approximately 5 days. Strains typically present as generalized soreness in an area after a change or increase in activity. Bursitis is typically activity related and is generally quite obvious on exam by the time a patient appears in your office and seeks treatment. There's inflammation of the bursa with pain. The inflammation can be quite dramatic. I've seen it as big as tennis balls on people's elbows. The thing you want to assess for with bursitis is infection. You want to check for any sign of cellulitis or a puncture wound over the area. The only definitive way to rule out suspected infection is to aspirate the fluid. However, by introducing a needle, you're obviously increasing the risk of infection, so you want to proceed with caution that way. With greater trochanteric bursitis, there isn't an obvious inflamed bursa like there is on the elbow or knee. A key exam finding there is tenderness to palpation over the greater trochanter. With elbow, knee, or greater trochanteric bursitis, the pain is greatest with flexion of the joint. There is no diagnostic test for bursitis. The diagnosis is made based on clinical presentation. Tendinitis, tenosynovitis, or tendinosis as it now is more commonly caused. These conditions are common among athletes and laborers whose work involves overuse or repetitive use, but they also occur in older patients with no known etiology or exact pathophysiology isn't known. It's not sure if inflammation is present in all forms, thus the term tendinosis is becoming preferred. There does appear to be a degenerative component as well. Common sites I have listed here. These conditions are generally diagnosed clinically. X-rays can be utilized to rule out other diagnoses, but they will not demonstrate tendinitis. Elevated SED rate may be present. Localized tenderness and pain that's worsened with motion and stretching the tendon are your typical findings on exam. Fractures. This slide and the next slide I copied and cut and pasted from Up to Date. There's pictures and descriptions of the various types of fractures. Again, it would take me multiple slides to go over each one of these. So this is a nice succinct description of each of them. The vast majority of fractures occur obviously as a result of trauma. Compression fractures of the spine in elderly and pathologic fractures are exceptions to this rule and typically present without any history of known trauma. When describing a fracture, you describe it according to the bone involved, the location of the bone where the fracture's at, say metaphysis, diaphysis, or epiphysis, orientation, transverse, oblique, or spiral, and then condition of the overlying tissue as an open or closed fracture. And as I mentioned previously, anytime there's an open wound near a suspected fracture site, you should assume it's an open fracture until proven otherwise. As fractures generally occur secondary to trauma, you will typically assess for fractures after ruling out other life-threatening injuries. Some or all of the symptoms listed at the top of this slide may be present with a fracture. Typically, point tenderness will be present over the fracture site. The mechanism of injury is particularly important when obtaining the history of present illness. Examination must include assessment of the neurovascular status of the affected limb. You'll want to assess the entire length of the bone and at least the joint directly above and below the suspected fracture site. The rule of thumb is to splint a suspected fracture as you find it and not to manipulate it or attempt range of motion testing until after x-rays. The exception to this is if there is evident neurovascular compromise. Diagnosis of fracture occurs via x-ray, but the correct views must be obtained. The American College of Radiology provides guidelines for clinicians to determine the most appropriate imaging choices. I'm attaching a link here on this slide. You'll want to page down several pages before you get to the musculoskeletal trauma/pain section. And remember that fractures may not be visible on x-ray initially. Once the margins of the fracture have absorbed and new bone is produced at the fracture line, it becomes more obvious on x-ray, and this can occur 7 to 10 days after the injury. Gout. It's the most common inflammatory condition in older adults. 10% of people with gout just have the one episode and then done. 50% proceed on to suffer chronic gout symptoms. It's difficult to diagnose as it mimics other conditions and can occur at the same time as other conditions. Excuse me. Hypertension, renal disease, heart failure, and the diuretic use associated with those conditions, as well as diabetes, cardiovascular disease, obesity, family history, hyperlipidemia, and metabolic syndrome all put patients at greater risk of gout. Alcohol consumption and a diet high in purine, organ meats and seafood, also elevate patients' risk. Gout used to be referred to as the disease of kings, as only royalty could afford to eat those types of foods. Multiple medications contribute to increased risk of gout. There's an extensive list in the Kennedy text. Diuretics, both thiazide and loop, are the medications most commonly associated with gout. Confirmatory diagnosis of gout is made via joint aspiration and polarized light microscopy that demonstrates monosodium urate crystals in the synovial fluid. Joint aspiration is also appropriate means of ruling out septic arthritis or pseudogout. If patient appears toxic, blood culture should still be run even if you find the crystals in the synovial fluid, because the patient may have both gout and be septic. Serum uric acid level, CBC, serum creatinine, and BUN should be drawn to evaluate for hyperuricemia, sepsis, and renal insufficiency. Sed rate and C-reactive protein may be elevated in any inflammatory condition, but will not aid in distinguishing one from another. That it's important to note that the textbook presentation of gout with the great toe, may or may not be what you see. You can find it in joint or joints. Low back pain. You will undoubtedly see many patients complaining of low back pain, some chronic, some acute. Your job as a primary care provider is to rule out any serious condition, such as cauda equina, metastatic cancer, multiple myeloma, or aortic aneurysm. As you see here, I think what's most important to note, I guess a couple of things on this slide, is that an overwhelming majority of the population experience low back pain at some time, and that a full 30% of adults are walking around with herniated discs but are asymptomatic. So oftentimes when somebody presents with low back pain and then is found to have a herniated disc, you're assuming that those symptoms are related to that, when I'm not so certain that that's necessarily the case. I think we move beyond conservative treatment way too quickly with low back pain. Past medical history should be carefully reviewed for any conditions that put patient at risk for aortic aneurysm, multiple myeloma, or metastatic disease. History of present illness is important to determine if there's a history of trauma or injury, and to assess pain via the old cart method. Low back pain may be acute or gradual onset. It's typically aggravated by coughing and or sneezing, requires frequent position changes, and may or may not radiate into the buttock, thigh, lower leg, or foot. You should review again the spine examination demonstration included in the website under this week's readings. Any patient presenting with low back pain with radiculopathy and fever should have immediate MRI to rule out the rare spinal abscess. Cauda equina, as mentioned earlier, is also an emergency. Otherwise, a trial of conservative treatment can be attempted before proceeding with diagnostics, as long as there are no red flags identified. And when and if diagnostics are undertaken for low back pain, they include plain films, MRI, and or myelogram. And here on this slide, I've outlined the findings that depending upon where a herniated disc is, like L4-5 or S1, you'll see these various findings with where the sensation changes are, where the weaknesses are seen, and then what reflex is affected. Osteoarthritis is a very common occurrence. It's not age dependent, but it does occur most commonly among the elderly. Etiology of osteoarthritis is not totally understood, but it's known to have both a mechanical and biological component. The pain of osteoarthritis is related to increased vascular pressure, stretching of the joint capsule, pressure on ligaments, muscle spasm, bone spur formation, and inflammatory irritation. Risk factors include age, female gender, obesity, history of joint injury, positive family history of osteoarthritis. Some occupations and sports activities involving weight-bearing joints increase the incidence of osteoarthritis. A diagnosis is typically made based on clinical presentation, exam findings, and x-rays. For weight-bearing joints, standing x-rays should be taken. X-ray findings with osteoarthritis include joint space narrowing, cyst formation, and bone spurs. Polymyalgia rheumatica, PMR, is 2 to 3 times more common in females and typically occurs in patients over the age of 50. They'll present with fatigue, aching, pain, and stiffness in neck, shoulder, hips, and pelvic girdle. It's onset of morning stiffness, aching with exertion. Initially may be unilateral, but typically progresses to be bilateral. Systemic symptoms include low-grade temperature, anorexia, depression, weight loss, and general malaise. 50%, this is important to note, of PMR patients develop giant cell arteritis. So it's thought that they may be actual manifestations of the same disease, but that's not clear. Because giant cell arteritis occurs so frequently with PMR, assessment should address vasculitis symptoms such as headaches, visual disturbances, fever, jaw and tongue pain, sore throat, hoarseness, choking, cough, ear pain, painful scalp, and limb claudication secondary to vascular occlusion. Check temporal arteries for tenderness and check visual acuity. Fundoscopic exam may show retinal hemorrhage, cotton wool patches, and edema of the optic nerve or optic discs. And again, there's no definitive diagnostic for PMR. It's generally made based on clinical presentation and response to treatment. Rheumatoid arthritis. AIMS-2 is a symptom questionnaire that you should utilize to determine the impact of rheumatoid arthritis on your patient's daily functioning. Physical exam says MCP, wrist, PIP, MTP, shoulder, ankle, and elbow. Range of motion, tenderness, erythema, warmth, and swelling. Hyperflexion of the PIP joints with flexion of the DIP joints, called the swan neck deformities, are typically present, as is flexion of the PIP and extension of the DIP joints, known as the boutonniere deformity. A gentle squeeze test for joint tenderness over hands and feet can be useful for assessing severity of exacerbations. Skin should be assessed for subcutaneous nodules. Systemic evaluation should include eye exam for keratoconjunctivitis, scleritis, and corneal ulcers. Pleuritis, pneumonitis, and pericarditis can occur, so lung and cardiac assessments should also be included in your evaluation. Nerve entrapment and sensory neuropathy should also be assessed. Diagnosis of rheumatoid arthritis. X-rays will reveal soft tissue swelling, symmetrical joint space narrowing, and joint subluxations. Diagnostic labs are rheumatoid factor, sed rate, and C-reactive protein. The anti-CCP antibodies actually are found to be more sensitive and specific for RA and can be detected before the rheumatoid factor is elevated. That is the better direction to go with that. I know we've covered a lot. Yet again, orthopedics was one of my areas of specialty, so I feel like, oh, I don't get to cover everything. There's just too much. So I tried to hit on the ones that you'll most commonly see in primary care. So post any questions you have it on the course communication site, and have a good week.